And good morning to our online virtual attendees as well. Welcome to day 2 of the GDHF 2025. Thank you for joining us. Thank you for streaming in. You are at the right place. Do not leave your machines. For those of us who are still outside, we're welcoming you in so that we can get started on day 2, which is going to begin right away. So let me just start by asking, how was day 1 for all of you in the room? Please, just again, I was a teacher and I was a bad teacher. I wanted my students to shout at me. How was day 1 for all of you? Thank you. I love that energy. We have a very, very packed day today, as yesterday was. Provocative, fun, inspiring sessions. Happy hour yesterday was incredible. And today we have several plenaries. Just a reminder, we have our agenda online. For those of you who might be stuck, those of you who are joining us today for the first time, this room will be divided at some point, and this is ballroom 1, ballroom 2, ballroom 3, depending on how many times we'll divide it. And below us is where we have meeting rooms A, B, and G. And we also have 10th floor, the clubhouse. So there'll be multiple areas we're using for breakout rooms as we go along. Do not get lost. We have our volunteers. Nduta is there as an example with her green branded GDHF shirt. They're here to help us and help you go along. Reminder, your badges are your meal cards and your entrance tickets. Please don't lose them. You have the agenda at the back of them as well that you can use. Those of us who are joining us today, the Wi-Fi is GDHF 2025 is the Wi-Fi name, and the password is Digital Health, one word, capital T, capital H. We have our pop-up studios that will be happening for our folks online. Stay tuned for that as well. And a reminder of the hashtag GDHF 2025. I want to applaud, and I'm going to ask you to please give yourselves a round of applause, because last night I spent an hour and a half liking every single post, and there were many. Let's keep that going again today. Day 2, GDHF 2025 is the hashtag we're using, especially on LinkedIn. 2 quick things I wanted to let us know about yesterday as well. When we have the tea breaks, inspiration happens in here, and collaboration happens out there as you network and have your tea breaks. Because of that, I really hate to pull you all back into the room, but we do need to be keeping on time. So when you hear that bell, it's not a bell, okay, now I have 45 minutes to wrap up my tea. It's, you can start moving in immediately. Just you'll hear the bell. It's not to force you in. I know one of our panelists today wanted us to ring the bell right now as well. So we will be doing that. Oh, there he is, hiding. We will be doing that across the day. If you hear the bell, please know we're just encouraging you to come back so that we can again be inspired in here and we collaborate outside. And as a final couple of things before we get started, number 1, I do have an activity that I want us to do, a bit of a warm-up energizer activity. Before that, though, I was told that we have so many global guests visiting, and I have not taught you a single word of Swahili, not even one word. So I have a very, very simple lesson. It's going to take us 30 seconds. Very extremely simple Swahili. So are you all listening? Do you all have your pens and papers in front of you? Because you're going to need to repeat it back to me once I'm done. So it's very simple. In Swahili morphology, particularly with the Ngeli ya U na noun class, which covers numerous animate and inanimate nouns, we observe subject markers and object infixes that must align with semantic plurality of the referent. For instance, the noun Ngonjwa belongs to the class. So in agreement, Ngonjwa umeenea, the illness has spread, where U triggers the appropriate subject marker U in the verb. Now when nouns undergo locative derivation, we apply the ni suffix to indicate spatial interpretation, right? Producing a form with entirely different morphosyntactic behavior. Okay? So for example, Hospitali ni is in or at the hospital. Nyumbani ni is at home or in the house. Of course, once localized and locativized, these nouns no longer behave like the standard u, na nouns. Instead, they demand locative agreement, such as pa, ku, mu, depending on their diacritic anchoring in the topographic, depending on the nuance. So, with all that said, I believe you've learned a bit of Swahili now, and we are ready to move on. No, very basically, if somebody says habari asubuhi, it is technically, literally, it is news of the morning. Habari means news, asubuhi is morning. So if I say habari asubuhi, then you can all respond mzuri, which is good, assuming the news of the morning is good. So habari asubuhi is how are you? So I'm going to ask, habari asubuhi? Great. And another one you can say, I can ask when greeting many people, have you all heard of jambo? So when it's many people, it's ham jambo. So I'll say ham jambo, like hi to many of you, and you will respond by saying hatu jambo. So just those two for today. Tomorrow I'll give you a few more health-related ones. Good to see you. All right, so hamjambo. Habari zenu. Very good. Fantastic. Oh, give yourselves a round of applause. This is an audience and a half. Great. Now, finally, I want us to get started. And I promised I would do a very short activity. And for that, I'm going to need a volunteer to join me on stage. Who wants to volunteer to come on stage? Actually, yes, one volunteer. That is Peter. Peter, please join me on stage. Let's give Peter a round of applause. And I'm going to ask all of us to also rise to our feet because this is an activity that needs us to be standing, and I'm going to do this for 30 seconds so that we do not take too long. And it's going to be a very simple activity. Okay, so in a moment, you're all going to copy me, and Peter will stand back to back, okay? Back to back, back to back, okay? It's a simple mathematics game to get the brain jogging, right? I'm going to be counting down. I'm going to count on 3, 2, 1, and then what you'll do with your pair, so make sure you're paired up with somebody, meaning if you're sitting all the way at the back, you need to come all the way to the front because there are unpaired people all the way here. I'm going to ask you, I'm going to count down 3, 2, 1, and then what you and I, or what you'll do with your pair, Peter, is we immediately jump, and well, you don't have to jump, turn around, okay, and you'll hold up a number. Okay. 1, 2, 3, 4, 5. You can use one hand, you can use both hands. Okay. And between you and I, we need to add the two, your number and my number, and shout out the correct answer. So the first person to shout out the correct answer sort of wins the little game, has won. Yeah, and because this is on camera, what's that, Peter?
There's accountability, right?
There's accountability. Yeah. There's accountability. Okay, so does everyone get that? Did everyone get that? Okay, we'll do one quick dry run, Peter and I, and you can watch us. So Peter, in 3, 2, 1. 4. Okay, who won that? I'm not sure. Now everybody, back to back, back to back, back to back. Those of you who are joining, please come fill the seats in front. Please come, the seats in front. Come to the front, come to the front. All right. Everyone, are you all back to back? Are you ready? Who does not have a pair? If you do not have a pair, make sure you are paired. Or you're going to do 3 people. Oh, I love that. That's a lovely modification. Okay, I'm going to steal that going forward. All right, in 3, 2, actually, Katie, I need you to be here. I can't be doing this. I need to watch. Everyone give Katie a round of applause, one of the core members of the Tech Change team. All right. In 3, 2, 1. All right, how many people won in their little groups? Wait, why am I seeing both people putting up hands? There can only be one winner. All right, one more time. Back to back. All right, in 3, 2, 1. Fantastic. All right. Some of you, wait, Katie, wait, we're going to do one more round. Please stand up. One more time. This will decide the winner. Some of you are actually jumping physically, and I appreciate that and applaud that. This time, we're multiplying. So it's multiplication. Yeah. Remember, you can use both hands, you can use one hand. In 3, 2, can we get the cameras on everybody so that we really have this streamed for everybody at home? And if you're watching us at home, please do the same with whoever you can find with you. All right, in 3, 2, 1. All right, fantastic. Please give yourselves a round of applause. Excellent. Some of you learned the trick, and I'm going to whisper it so that, you can use it next time. But the multiplication part, the easy way to cheat is just keep 0, so that the answer is always going to be 0. But you didn't hear that from me. All right, great. Fantastic. Thank you so much for that. One more time, give yourselves a round of applause. Fantastic. Okay. We now want to get started officially with our day 2 agenda. And we're going to have back-to-back plenaries, one for AI, for eCHIS. We'll be talking about, that's past, present, and future of digital economy. We're also going to have a discussion on strengthening primary health care through digitalization and understanding the World Bank's collaborative impact across countries, and also to the full stack future, building an open digital health ecosystem. So it'll be back to back. Encourage you to strap in. We won't really have any long break before then. Of course, tea, washrooms, all of those are in the same area. Again, I'm going to ask us as we come in, and we'll be asking our volunteers maybe to usher people towards the front so that there's space for people coming behind. But as mentioned, we want to get started with our first plenary panel session, which is AI for eCHIS, the past, present, and future of digital community health intelligence, brought to us by our lovely friends at AMREF and Dalberg. I'm going to introduce our moderator, who's going to take us through this first session and introduce all the panelists as well. And that is, of course, none other than Miss Aika Matemu, who is a senior advisor and partner at Dalberg Design, where she supports businesses, governments, and nonprofits across emerging geographies to reach underserved markets through human-centered products, service, and design. She works at the intersection of design, social impact, and global health, bringing a mixed methods approach that blends qualitative and quantitative research to surface deep insights and drive meaningful innovation. Ladies and gentlemen, with a round of applause, were you here, Aika, yesterday? So she doesn't know, she wasn't here yesterday, she doesn't know the sort of applauses we give her GDHF. Ladies and gentlemen, let's welcome her to the stage!
Thank you so much. Good morning, everyone. It is such a pleasure to be moderating this particular panel. My name is Aika Matemu. I'm a human-centered designer. I am very passionate about the intersection of design and innovation and social impact, and really excited to be speaking with these particular panelists. For more than a decade, digital community health information systems have been one of the most important building blocks of digital health in Africa. And today we find ourselves on the edge of a new chapter as AI begins to take shape within our health systems. In this session, we will walk together through where we've come from. Where did we come from before digital community health systems? Where are we now, and what does the future look like? And we really want to understand from our colleagues here. We'll get very special insights and nuggets from Kenya and Zanzibar and across the ecosystem. So I encourage you to listen, and we will have a chance to ask questions at the end. But without further ado, please join me in welcoming our very distinguished panelists to the stage. First up, we have Mr. John Wanyungu from the Ministry of Health, Kenya, who is the Deputy Head, Division of Community Health, and also serves as the Strategic Information Management Lead, with over 20 years' experience. Additionally, John is the co-chair of the Community Health Unit for Universal Health Coverage, which is a platform that brings together all partners leading community health work in Kenya. And he has been very much at the forefront of eCHIS implementation. And then following John, we have our neighbor, Mr. John Mahundi, who is the Head of Technology and Data Analytics at Zanzibar's Presidential Delivery Bureau. He drives digital transformation initiatives for President Dr. Hussein Ali Mwinyi, focusing on health tourism infrastructure, the blue economy, and social services to enhance Zanzibar's development. And of course, it's good to hear from the national level, but it is also very important to hear from the sub-national level. So we do have representatives from the county. Ms. Anne Wanyaga Mwaniki is the County Director of Public Health in Machakos County and a dedicated community health specialist with advanced training in nursing, community health, and research. She is also the founder of Chama Champions, an initiative grounded in the belief that health and economic empowerment go hand in hand. And how can you have a conversation about community health without actually having community health workers? So we are very lucky today. We have a community health assistant from Machakos County, Ms. Anita Kaleli, welcome, who has a diploma in community health and HIV/AIDS management. She has extensive experience delivering community-based health services firsthand and is deeply committed to ensuring that every household receives quality and equitable care. We are also joined by industry, my colleague, Ms. Rosisa Zaimova from Dalberg Data Insights. She is the CEO and co-founder of the data and AI arm of the Dalberg Group. She leads work on contextualizing people-centered AI across low and middle-income countries, with a strong focus on strengthening public health systems through responsible and grounded AI. And then last, but definitely not least, we have our representative from AMREF, Dr. Meshak Ndirangu, who is the Country Director, Kenya, for AMREF Health Africa, and is a forward-looking public health leader known for shaping organizational strategy and driving high-impact programs that expand access to care for millions. Please join me in welcoming these fantastic panelists. So we're going to start with the national level and understanding what has happened at the country level. We know that in Kenya and also in Zanzibar, both countries have been fortunate in implementing national-wide digital health community information management systems. And so I welcome Mr. John Wanyungu to speak to us about what the experience has been like. You've been at the heart of the journey. What were Kenya's key eCHIS implementation milestones, and what critical lessons from scaling up implementation can inform the approach to adopting AI today?
Thank you very much, Aika. So good morning, everyone. Right, so the milestones we have gone through implementing electronic community health information system in Kenya, that's eCHIS, is dating way back in 2020 when the country decided to digitize delivery of community health services in the country. And so for a start, we defined the software requirement specifications to guide how we develop an app that would help us go digital in Kenya. Then secondly, we were also aware that there were other apps in the country that were being used in community health service delivery. So we went out to look for them. We did landscape assessment in the same year, 2020, to try and find out what systems were being used in the community health service delivery. And we found so many of them, close to 20 different apps. So we looked at all of them, comparing each one of them to our SRS. And then we found one that was close by our software requirement specifications. We adopted it as a country and began enhancing it. So by 2021, we already had a national prototype for eCHIS, which we piloted in Kisumu County. And with the learnings we got from the pilot, we were able to come back and enhance eCHIS for the country, which then we went ahead to do a second pilot again in the same year in Migori. Now the second pilot now gave us more insights and we were able to improve on our eCHIS. We began deploying with a plan to deploy it to the whole country in 5 years' time. However, in 2023, we got good support from the national government that came in and supported the deployment of eCHIS countrywide by kitting community promoters, 100,000 of them. And in the kit was a smartphone. We were able to give it to CHPs and we use those smartphones to train them to use eCHIS. They were trained with a lot of support from our partner organizations. So it was a collaboration between government and partner organizations. So we were able to fast-track rollout of eCHIS countrywide by the year 2024. We had deployed eCHIS to the whole country, covering all the 100,000 CHPs in the country. So another milestone then was after we deployed, we continued with the enhancement of the system to be able to meet user needs. So that continued, and as we speak now, eCHIS is very well enhanced given the feedback we get from system users. And so the system is now stable. The other big milestone that we experienced was when we decentralized user management. Before we were managing users at the national level, it was very hectic to onboard all system users centrally. So we developed a tool and then decentralized that tool to counties. Now we got counties managing the users, onboarding them, moving them around, removing those who had dropped off the service delivery and adding new ones. Then the other big milestone we had when we went countrywide using eCHIS is we had a challenge with data transmission because it needed data bundles for people to transmit data. But then the government came in and whitelisted the URL link for eCHIS so that CHPs could be able to synchronize their data to the national servers without having to incur any expenses. That was another major milestone. Thereafter, we've had HIE, Health Data Integration, which is a platform that then allows systems to communicate. So we've had to integrate eCHIS to HIE, meaning then we are able to make community facility referrals, which wasn't happening there before. That has been tested and now it's working. And lastly, the other major milestone is integration of AI in eCHIS, which we have done with tech support of Amrev and Dalberg. And that has been tested in Machakos and seems to be working. The AI is focusing on an issue of getting quick reports, summary reports on key performance indicators. Within the CHAS, like Anita here, are able to use that to engage with the CHPs and be able to discuss performance of individual CHPs from the data that comes, report that they get with the use of generative AI. So those are the milestones that we have gone through with eCHIS from inception up to where we are today. Thank you very much.
Thank you so much, John. Impressive ability to scale up a digital platform to 100,000 CHWs. I think there's a lot of lessons there that you have packed into your update, and I think it's really incredible to see that with one digital system, when you're introducing new innovations such as AI, it just feels a lot more centralized because you're not having to work with 20 different providers, as you mentioned. And so now, moving to our neighbors in Zanzibar, Mr. John Mahundi, your island has had a very unique journey in adopting the Jamini Afya platform, which is a digital health community information management system. What has the experience been like? It would be interesting, you know, we're comparing now two different countries. What has the experience been like? What are some of the similarities that you've heard from Kenya as well?
Thank you. Good morning, everyone. So to understand where we are today, I think it's important to kind of take a look back at where we started our journey. About 2 years ago, we made a very intentional effort to make sure that our house is in order. As many of you know, when you're interacting with the Ministry of Health, there is never a shortage of stakeholders, right? So you have development partners, you have implementation partners, you have the ministry's self-directorates that are trying to do so many different things within the Ministry of Health. So for us, step one was to get our house in order. It's more than just stakeholder management, it was stakeholder engagement that got us to where we are today. So we created a platform and created a forum where all key stakeholders that were engaged with the Ministry of Health as far as digital transformation or digital health goes, have a platform to interact and understand what each one of them is doing. Not only understanding what each one of them is doing, but also taking the good from each component that some of these people have worked on. So talking about the EMR system, electronic medical record system, talking about vertical programs and so on. So in doing so, we looked at where we are at the community level, where we need to be at the primary level, district, and regional. Because at the end of the day, the person that you're interacting with at the community level eventually has to interact with the rest of the levels of health provision or healthcare provision. We took about 6 months to make sure that that went well. We agreed on, from 42 systems, I think is where we started, to narrowing it down to what's really needed, including identification points of our patients. So we went through that journey and got to a place where now a person that's interacting with our system from the community can seamlessly move from a digital perspective all the way to the regional level. We're talking referrals, talking data information. We used to carry what they call Mabuk, Vitab, to take into hospitals. They're no longer doing that. Now, as we have gone to that place and we feel a bit more matured, we have adapted digital systems, is how else can we empower our community health workers? And that's where AI comes in, and that's where what we have done with Jameen Yafia comes in, is now we want to give our community health workers superpowers. So now they can be out there with early diagnosis, decision support systems, and so on and so forth. That has been successful so far, and we're really looking forward to what else can we put in the hands of our community health workers to get us to where we need to be. Right now, meetings are run a lot better because of AI tools. Calendars are managed a lot more efficiently. Communications are disseminated a lot better than where we are 2 years ago. And we're really excited about what AI can do for us. And again, just to emphasize, is basically giving our community health workers superpowers so that they can do what they do best in ways that they've not been able to do before. Thank you.
Thank you so much. I really love what you said about giving community health workers superpowers. I think that's really meaningful. But something you've said is important. Getting your house in order before this adoption of a national system, and using stakeholder engagement as a way to drive buy-in. And I think increasingly with any sort of digital adoption, particularly those that are coming through the public health system, meaningful stakeholder engagement, including meaningful end-user engagement, is really important. How do you involve the community health workers in the design of these systems? And so now moving to the county level, Ms. Anne Mwaniki, Machakos has had great success in adopting eCHIS. Machakos is also the first county that is integrating AI into the eCHIS platform. What has this transition been like for the county? What have been some of the challenges, successes, opportunities that have come up through this transition?
Thank you so much. One of the things I would say, I think eCHIS was one of the best things that has happened to the community health system. And just to look at how we rolled it out sometime last year, the excitement, the pride that we are moving to be digital, moving from paperwork, moving from challenges of I need to photocopy reports, I don't have enough paper, I mean 2,870 CHPs need to submit reports to their community health assistants. They have to submit to the sub-county level and again to the sub-county level. Now, making it better is that I, from my seat as the director, am able to log in and see what is happening at every community unit in Machakos County. The county community health focal person is able to see what is happening, clearly saving a lot in terms of the paper that we are using and the time wastage from the diverse topography of Machakos County. But keen to say is that my team received this with all mixed reactions. It was excitement among the CHPs. I remember when we were training, to see them getting new phones and I mean learning new things. It was also a moment of anxiety. How will we move? We are used to paper. For all years that community health has existed, they have not done the phone side. Some obviously challenges with digital literacy, and we had to come in and really support them to ensure that they are able to cope, they are able to capture this data, and this data is well synced. Great wins are there, but then some of the challenges, like I said, the digital literacy, sometimes, and I like it that Mr. Wanyongo has highlighted it, the Ministry of Health has continuously continued to make sure each is working. He will tell you sometimes we have our downtimes, and those downtimes means then we are like switching back. But then the beauty and the success is that as we go every single day, improvement is happening at the eCHIS platform. You are able to view data. From where I sit, I'm able to see which CU is reporting more cases of diabetes, for example. Which CU is reporting, I mean, how many referrals are we getting from mothers that are pregnant, and we're getting them from the facility level. This alone means that we at the county level, when we view these dashboards, we are able to know where are we putting more focus, where are we trying to supervise more. And I look at my sub-county community health focal persons, as they analyze the work that is being done at the CHPs, as they focus on improved supervision. Some of the game-changing thing is, I am able to know every single day of my life what is happening in every CU. I'm able to view which CU is dormant. I'm able to know who is not working. What can we do more? Coming to the journey of eCHIS AI, because I've told you, if you look at the eCHIS platform, wonderful. But then, shortages will always exist. And once CHW, like Anita will tell you, maybe supervising 50 CHPs. You may not have to interact with them. Those are 5 CUs, 50 CHPs, several households. But then the eCHIS AI is coming to help Anita look at the data health trends. What is happening in a certain CU? Are they reporting more TB cases? Is there a death that is being reported? That way, she's able to prioritize, where do I start? Where do I go? What do I focus on when I go for a community dialogue in a certain CU? And this is making it easier for us. And obviously, we look forward to a point where it will move then from the CHW alone, it will come to the level of the sub-county level, and obviously at the county level, we will have the view of the dashboard of the eCHIS AI. The other beauty thing is about, maybe I need more information about a certain condition I have seen being reported. The CHW is able to say, let me read more. And the eCHIS AI is able to give some insights on some information that she may need. So interesting moments there. I would like to say that one of the things that is also making it win, and I must say this, is there is great support looking at the national level and also counties, political goodwill to the community health systems. Because we have moved from a point where CHPs were not recognized to a point where from the national level and all counties are recognizing them and paying them subsequent stipends, which is a good thing. Continuously training them on the basic modules and empowering them. Thank you.
Wow, thank you so much. You have highlighted two very important things. And the first one is that it is critical to always refine your product. Ultimately, the tool is really supporting community health service delivery, but the tool needs to make sense. And so using data and evidence from community health workers and others who are using the platform to continuously refine it. It's not enough to just deploy a digital tool, it has to be continuously improved. And then you've also highlighted how information and data at all levels is really critical, not just for decision making, but also for knowledge building as well. Because it does feel like now CHWs have a lot more access to information from this AI platform, information about what sort of health topics they should be discussing. Also, what CUs are performing better than others. And this information is intended to strengthen that service delivery model. And so it does feel like information is also a tool, a superpower, as Mr. John mentioned. So I'm going to switch gears a little bit and let's talk about the present, where we are now in the age of AI. And I'm going to welcome my colleague Rosie to talk about how is AI shaping frontline systems? And I think the bigger question there is how is AI as a technology really shifting the way in which we're thinking about service delivery and even the ways in which we're designing products for the health sector?
Thanks, Aika. And maybe before I speak about AI, let me play back a few numbers, a few statistics that Joanne from the Health Tech Hub yesterday brought up that I think are really important for us to start with. 24% of the health burden in the world is on the continent. 3% of the health workforce is here, and 1% of the financing is here. So when we think about superpowers and think about frontline workers, yes, we need more superpowers because it's less likely that we add another 1 million community health workers tomorrow than it is for us to embrace responsible and people-centered AI. So we as Dalberg Data Insights, we've been working very closely with Ministry of Health in Kenya, with AMREF, with D3 in Tanzania and the Ministry of Health in Zanzibar to design AI-enabled applications that improve supervision. And when we think about AI, AI thrives when it's deployed to solve real problems and embed in real workflows. And when we think about workflows, we have Anne, we have Anita, they already shared a little bit about the very busy day of community health workers and supervisors. They spend time between health units, they spend time reviewing data, specifically supervisors and CHAS. They look at data from community health workers. They're the ones that detect early health burdens and health trends. They're the backbone of community health. They're there to support the community health workers. And here's where AI can thrive, right? What we did is develop an application, an AI-enabled application that uses data from eCHIS that basically generates automatically health trends for community health supervisors and CHAS and help them prepare for the meetings with the community health workers faster and better. The application is also able to basically flash and flag data reporting issues so that CHAS and supervisors, they don't act blind. They now have access to real information and in a natural language way, right? What better way to know data than to ask in your own language what is happening when it comes to health burden and what is happening when it comes to data reporting, right? So that's what we've been working on, and I'm really excited to also be part of this panel simply because I think the composition of it is a representation of what we need to be able to see successful AI applications scaled. We need ministries of health to fully lead the way and embrace AI. We need community health workers, supervisors, we need community health leadership to be behind, and we need technologists, right, to be able to support. So thank you for having us today.
Thank you so much, Rosie. truly inspiring. And like Rosie mentioned, actually, all of us in this panel have been part of this AI integration into eCHIS journey. And it started by a lot of what you've heard: stakeholder engagement, getting buy-in, bringing in the right levels of government. But I think where we actually spent the most time was with community health workers. We went into Machakos County, we went into Zanzibar districts, we spoke to many CHWs of different types of experiences. It's a very diverse team, actually. We spoke to their supervisors, and through all of that, we were able to generate insights that actually translated into AI use cases. So the AI use cases were not designed in a boardroom by a bunch of consultants. They were actually designed by community health workers. And I think that's the most powerful thing, because that is where inclusive and meaningful design really needs to sit when designing for anyone really, but particularly for health workers. And so now I would like to introduce and reintroduce our community health assistant, Anita, to share with us your experience with eCHIS, past, present, future, your experience with the superpower of having AI within eCHIS. What has that been like for you?
Okay, thank you very much for that question. Good morning, everyone. So I'll start by giving a brief history of how we came to eCHIS and then integration of AI into eCHIS. So before all that happened, some decades way back, we used to do paperwork to report, collect, and record community health data. So we had the tools like MOH 513, which is used by the CHPs to do household registration. We had MOH 514, which is a service delivery logbook. We have the 515 that is used by the community health assistant. And then we had the 516, which is a chalkboard. So all those tools, the reporting method was manual. We used to do papers. So with that experience of using papers, there is likelihood that data will get lost at any point. The submission of the report was physical. You have to move from one facility to another to give the data. Then it was time consuming because one community health assistant runs about 60 to 70 CHP. And while looking at that, that is a lot of work. So it was definitely time consuming. And then there is heavy workload. And still the books are so heavy to carry from one area to another, basing that our work is in the community. So it was really hectic. Then we came into eCHIS. We transformed into eCHIS, which was rolled out back in 2023. And it has been an amazing journey. It has been a transformative journey for us. And it has helped us in the community work, whereby now we can record, collect, and report the data more accurately. There is minimal errors because now the paperwork, we are done away with the paperwork, and it's time saving, and also it helps in making improved decision because you are able to get the best report from it. So far eCHIS has been working so well, and we are so honored, and we appreciate the developers for doing an amazing job. We also appreciate the county government of Machakos for the support they have been giving us, because we have had so many trainings. Of course, not everyone is an expert in the IT sector, so there have been so many trainings, and so far all the community health assistants in Machakos County are conversant with the eCHIS. And now that we have had the opportunity to have the integration of AI into it. We still appreciate the effort from the developers, and the journey so far is amazing, and it is able to make our work easier. There is reduced workload. As I've said, as for me, I have 60 community health promoters, and with the help of eCHIS, I'm able to supervise all of them, because it shows me the number of households a CHP is able to visit in a month, the number of sinks a CHP is able to do. So I'm able to know which CHP is active, which CHP is not active. And also it's able to give the health trends in a community health unit, whereby you are able to know when there is increase in the number of TB cases, or when there is a need for referral, when there is a need for defaulter tracing, and so many other indicators. Basically, what AI is doing, it is fetching the data directly from the eCHIS app. So it is able to help in improving decision making, hence aligning better community health outcomes for our community members. So the journey has been so amazing, and with that, there have been challenges here and there. Like, for example, system downtime from time to time, whereby you need to access the app and it is not working at that moment. So you're not able to give a timely report. And also, for the CHPs, we could really like if you make the app to be able to sync automatically, because they have to buy or upload data bundles for them to use. Yeah. So if the app can be able to sync automatically, then it will make the reporting much better. Yeah. So far we appreciate. The journey has been amazing, and we are looking forward to having more developments done with the app or the tool. And we appreciate the support from our county. We appreciate the support from Dalberg team. We appreciate the support from all other developers that were involved in making eCHIS a success, integration of AI into eCHIS a success. Thank you.
Thank you so much. Thank you so much, Anita. And it's not often that you get this first-hand experience and insights from the actual community health workers. And you've mentioned that there's still challenges, and I think it's important that those challenges be elevated, because without that, then you don't have improvements in the system. I also love, I think one of the things we observed when we were doing design research for the AI solution, one of the things that we observed is there's such a strong ownership of the eCHIS platform by community health workers. You know, having the phone as your working tool, similar to the way you would have your laptop or any other work support tool. Having that phone and being able to do all your work on the phone really quickly, I think has incredibly transformed the way in which community health services have been provided. And so it's really exciting to see that type of innovation. And so now moving into the future, we've heard from Rosie, 1% of funding is on the continent. And we do know that really the next frontier or the future of health sits in transforming, optimizing primary health care. And it has been proven that there's a high return on investment when you invest in community health workers, and we see it. Now with the use of digital tools, we have seen really an increase in efficiency, but also an expansion of that service delivery package. CHWs can now do so much, you know. It's not just about collecting data about the number of pregnant women or the number of children born. They are now diagnosing, they're now dispensing medication, they're now providing health talks. And really, some of the most promising use cases sit around expanding that service delivery package, but also making work more efficient for them. And so, over to Dr. Meshach, who has been leading AMREF in Kenya. What are some of those promising use cases that you see for AI within the community health service delivery?
Thank you. Thank you very much, Aika. And it's amazing, speaking after Anita, who has painted the journey of meaningfully deploying artificial intelligence in our health sector. And today we celebrate a partnership of Dalberg, the county government of Machakos, the national government, and Amref South Africa being a catalyst. And as we move into the future, these are the types of partnerships that are going to help us transform the health ecosystem, specifically primary healthcare, where you have catalysts like Amref, tech innovators like Dalberg, the government, and also the use, including and also the users. Now, the Gen AI solution that this consortium has put together and tested by the users already demonstrates that potential of us to strengthen primary healthcare using AI. Because from a midline evaluation that we have undertaken, already we see that 3/4, about 75% of community health assistants like Anita are finding that the solution is enabling them see patterns they were not going to see without it. And literally 100%, 95% to be specific, of community health assistants who Anita represents here from our midline evaluation have shown that they find it useful and intend to continue using it. And as Anita has put it, our challenge is to keep listening to users like her, tweaking and building solutions that fully respond to their needs. Like the way she has put it, that our solutions need to be mobile first, low bandwidth solutions that can thrive even in the remotest of the areas. And I think that's a challenge we're being given today to build for users. But when you look at Kenya's digital health ecosystem, there are several other areas whereby beyond community health, there are several other areas where use cases are emerging, and we have every opportunity to take them through exactly what we have done with the Gen AI solution that Anita has talked about. We have heard from organizations like Peda Health and our partners, representatives from EDIA who are here, talk about clinical decision support systems. We need that immensely here in Africa to help us control the non-communicable diseases, specifically diabetes, high blood pressure, and all that, where we need to build the right cascades of care, the same way we did for HIV with a lot of pay for money, but now we don't have that money to control non-communicable diseases. So we have to invest in clinical decision support systems powered by AI, doing a lot of that heavy lifting. We have maternal and newborn health, and already at Amref, working with partners like Impala, we have seen solutions that are emerging that are reducing newborn mortality by 27% by helping newborns, nurses in newborns, monitor vital signs and predict which newborn is likely to get complications and so provide care much earlier. And the same thing for pregnancy risk. We are working with Safaricom. We have seen that we have opportunities like Uzazi Salama and Bump Buddy platform that are helping improve the ability of health workers to track, to detect the risk of complications much earlier and respond. And beyond that, we are also seeing amazing work in the space of infectious diseases like tuberculosis, where to date, with funding from Global Fund in Kenya alone, we have seen more than 200,000 people examined using digital chest X-rays that are AI-powered, and therefore making diagnosis for TB much faster, much easier, much more cost-effective within an environment whereby the average per capita expenditure on health is $100 compared to much higher elsewhere. So I think as we look into the future, It is for us to look at these use cases, pilot them, tinker with them the way we are doing with the one in Machakos, but always remember to build them for scale by integrating them into national health systems. The way the Gen AI solution is built on eCHIS, which is a national health system, all these solutions we build, that we are building here in Africa, all of us, we must ask, how will this go to scale? Which platform are we piloting it on that 1 year down the line, once we see it's successful, the model is working and all that, that we'll use to scale it up? Thank you.
Thank you very much, Dr. Meshach. I think you had some very many nuggets of wisdom in there. My big takeaway is around the contextualization. Contextualizing use cases for the people who are going to use them. And one example of that is in Zanzibar, the AI platform is fully built in Kiswahili, and Zanzibar Kiswahili, not Kenya Kiswahili. But you also raise other opportunities around clinical decision support, NCDs, diagnostics. I mean, there is a whole plethora of opportunities to design AI solutions for. But then we always say that it is not just a trend. It should not just be something cool that you're saying, you know, you have AI within your system. It needs to be deeply meaningful. And that's why integrating with existing systems, stakeholder engagement, getting buy-in, working with community health workers to co-design, all of those are really ingredients to get the applications that will scale, as Dr. Meshach says. And so now we're coming close to the end of our panel. We've heard a lot of wisdom from everyone. I would like to invite the panelists to share a closing note, I'm going to say note, sentence, a statement, and a reflection maybe coming out from this conversation. And we'll start with you, Mr. John Manyungo.
Yeah, thank you. So my final reflection around eCHIS implementation in Kenya is stressing the need of government ownership and leadership, which then drives the technology much faster than would happen if it was individual partners doing that. The other reflection is around the need for public-private partnership, government partnering with the partner organizations so that they're able to work together towards a scale-up of electronic community health information system. And also having a single application is very important, because when Kenya had multiple applications in the community, we didn't have visibility of those applications. It was until we came to a single application, that's eCHIS, and invited all partners to support it, that we made progress. And finally, there's need to go beyond pilot. Yeah. Because we piloted eCHIS, as I said, in Kisumu, and we did not stop at that. Instead, we aimed to scale it to the whole country. So even with the AI, we've done pilot in Machakos. We should not stop at that pilot. We need to scale it so that then all the 47 counties can enjoy the benefit of AI in eCHIS. Thank you.
Thank you so much. Mr. John?
All right, thanks. I think a few things would really recommend are important. For us to succeed in the journey that we have gone through, leadership matters. Ownership from the national level matters. It's not enough to just have the development partners, implementation partners, and people come in. For us to succeed as a nation, it was critical to make sure that we have the political will, we have the ownership at the national level. The second thing, I would really emphasize what you were pointing out is more user-centric solutions, because whatever we deploy has to actually go solve a problem that currently exists. Understanding what's going on the ground and deploying solutions that actually go solve a problem. Most of you, I think, can remember life before mobile money, life after mobile money, right? So if today you take away M-Pesa or any mobile money platforms from people, you probably start a riot, right? It has to be at that level. We should deploy solutions that people do not want to let go of, because they empower them, they give them a way to do what they need to do a lot more efficiently, a lot more successfully, And that becomes the critical piece. It's not just technology just for technology's sake. It actually has to go resolve a problem on the ground. Thank you.
Thank you. For me, the reason why we are here and Anita are sharing her story, it is because the first thing is leadership and political will. Under the leadership of our Governor Vinyandeti, she is the first person to support our community health promoters. We cannot speak of Anita working if the community health promoters are not going to the field and inputting this data. What is happening in some areas, we are seeing CHPs that are not motivated. So one from the topmost level is that all counties need to find a way of motivating their CHPs so these CHPs are involved. Number two, interoperability. I want to, when I'm in a level 2, is eCHIS communicating to GDHF, and I know the ministry is working on that, and we look at a future where from the dispensary level, the level 3s, we are able to say the disease trends that we are seeing are the same that we are seeing at the community, or there's something off. And then number 3, I look forward to eCHIS AI that communicates all the way to where I sit, so that I'm able to see, is it also helping me, helping my county team, helping my sub-county team to the level of the CHW. Thank you.
Thank you.
For me and the other chairs from across the country, we are ready to embrace the integration of AI into eCHIS and not ready to go back to paperwork. And for that matter, we appreciate our developers for the continuous effort you are putting to ensure the system is up to date and is working. And we are looking forward to have strengthened better community health outcomes from that. So thank you.
Thank you.
On my side, I started with a few numbers, and I'm going to finish with a few numbers. In our deployments, specifically in Zanzibar, what we saw is that 81% of the community health workers that have been supervised by supervisors that use the AI applications said that they would like their supervisors to continue using AI because they've seen and experienced improved supervision. 97% of the CHAS that use the application here in Machakos said that they would like to continue using it, that it's improved their efficiency, it's improved their workflows. So what that says is that frontline workers are embracing AI. They're actually ready for AI. But for AI to work at scale, as the co-panelist mentioned, it requires for us to speak about the hard questions. Who is going to pay the bill at the end? AI is even more expensive than digital because it is compute hungry and compute costs money. And we need to think about that and talk about that and solve for that. Because if it works and it solves real problems, we should be able to scale it. But what will it take to scale that? Yeah. And who should be in the room for us to be able to make that work at scale, right?
Thank you. My final parting shot is a message to all of us and to myself that here in Africa, we have a golden opportunity to meaningfully deploy AI to usher us into the age of precision public health, precision primary health care. And we need that because that's one of the ways we can manage to achieve impact and outcomes within our limited or within our physical spaces. And to do that, there are 5 principles that I would like to leave us with, and my colleagues have talked about them. Always start with a problem. We are problem solvers, not we are problem solvers. What problem are we solving for people? Number 2, co-create with users and in their context. Mobile, low bandwidth solutions, mobile first solutions, really thinking context. The third area is partnership. The way Ika has talked about the power of engagement, the power of partnerships. Always thinking about the 4 categories. Where is the government here? Who is the tech innovator? Who is the catalyst? And where are the users? And how are we creating with them? And you can see this panel has all the 4, which is amazing. And then the 4th is integration. Always asking, what rails will this thing we are building run on so that it can cover the whole country or the whole continent? And if the rails are not there, as my colleague from Zanzibar said, better start by building the rails, digital readiness, working with government to build the rails. And finally, responsible, equitable AI. Like in AMREF, we make sure all our solutions pass through the ethical review committee. We want to make sure they have ethical approval. We are 100% subscribing to the Digital Protection Act and all that, and they are built for equity. Thank you.
Thank you so much. Can we give the panelists a round of applause? A bigger one. Thank you so much to the panelists. Thank you so much to this collaboration. It has been incredibly fruitful. If you're curious about the timeline, it's actually been less than a year that we've been able to achieve this type of work. If you're interested in learning more, please approach any of the panelists, including myself, and we can share more information. But we are unfortunately out of time. There are big red zeros in front of me. And so I will request that we end now, and maybe with a photo. Yeah? Okay. Thank you so much.
Can we give them another round of applause, ladies and gentlemen? And if we can all stand for a group photo very quickly. As they are coming in, I can see that there are a few of us standing at the back. I'm going to ask us to, there are several seats, maybe a dozen